Hello friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. Hello friends, welcome to episode 14 of Sterile Field Guide. In this episode, we are going to continue talking about solid organ injuries. Oh my, did you hear the thunder? It's storming so bad outside right now, but listen, I am on a schedule and this is going to happen right now, so please enjoy the sound of rain in the background. We're going to continue talking about solid organ injuries, continuing on by talking about the liver, my second favorite organ. We talked about splenic injuries in the last episode. You should definitely check it out. Today we're going to talk about traumatic liver injuries. And when we talk about solid organ injuries, the reason why I'm talking about spleen and liver first is because liver and spleen are the most commonly injured organs in blunt trauma. And blunt trauma, again, are things like car accidents, motorcycle accidents, sports accidents, those sorts of things. So before we go too far, we should talk about how wonderful and beautiful the liver is. The liver has so many functions, and if you think about it, the liver is the only organ that we can't just replace for a little while. Okay, so like the kidneys, we can do dialysis. The heart, we can put you on ECMO. We can put you on bypass. The liver, there's no other option. Okay, you either have it or you die. And so the liver is very, very important, and we want to preserve it if we can. And so some of the things that the liver does, you may remember, it makes clotting factors. It helps to filter our blood. We know that when our liver's not functioning properly, we can get what's called hepatopulmonary syndrome from the endothelin 1 and the nitrous oxide because the liver is not working the way that it should. It also helps us make bile, helps us with our digestion of fats and fat-soluble vitamins. It stores glycogen. There's protein regulation, all sorts of things that the liver does that if we do not have it, if it is not working properly, what are we going to do? So while this is not an episode on liver failure, don't worry, we will talk about liver failure, we'll talk about cirrhosis and operating on cirrhotic patients, but just know that the liver is an excellent organ and we need to do our best to put it back together. That being said, the liver is like more complicated than we ever give it credit for. So when we think about the anatomy of the liver, this is going to be good things for you to review before you're going into a liver case, or if you're on like a trauma service, you don't know when that's coming. So just prepare ahead of time. But things that you want to review are going to be the portal triad. So remember that the portal triad is going to be your hepatic artery, your portal vein, and your bile duct. We know that the IVC, the inferior vena cava, runs posterior to the liver, and the hepatic veins join the IVC as it nears the diaphragm. So the veins are kind of more superior than the portal vein. I like to think of the hepatic veins as sort of like grabbing the liver like a claw. So they're kind of coming from draining from the bottom up into the IVC. Other things you want to think about are if you know that you have the portal triad, you know that you can do what's called the Pringle maneuver and clamp the portal triad, and that is going to help stop bleeding from the hepatic artery or the portal vein. You can also think about tributaries to the portal vein. So what makes up the portal vein? That's going to be our splenic vein, our inferior mesenteric vein, and our superior mesenteric vein. You can also start to think about things like the segments of the liver, which I think is something that we try to stop thinking about as soon as we learn it. But there are 8 segments of the liver. You can start to think about that. If you look at your hand, you can see the layout of the segments. I can post a photo of this on Instagram so that you sort of have something for reference. But basically, there's a lot of anatomy in the liver. You have your arteries, but then you have your subsections of your arteries that go to each segment of the liver, and there are 8 segments, and you need to know the sections, and there's all sorts of ways to slice the liver, and it can be very bloody and very crazy. And so reviewing the anatomy of the liver, reviewing the function of the liver is going to be important for just sort of knowing how to take care of patients. So for physical exam, this is pretty easy. This is stuff that you already think about with patients who have abdominal trauma. So something that we talked about last time are rib fractures. And so this time, rib fractures or chest trauma on the right side of the body is going to be something that's going to clue us into maybe there's going to be a liver injury. Something that I found interesting is that the liver goes up to about T4 or the nipple line with expiration. So as your lungs are compressing, your liver comes way up. So any chest trauma is cause for concern, not just lower rib fractures. This is also why we need to be super extra careful when we're placing chest tubes, because on the right side you can poke the liver in, on the left side you can poke the heart. So you need to be very careful. Putting a chest tube in is not a benign procedure. You do need to be mindful of what you're doing. We talked about diagnostic tests before, but the FAST exam, specifically Morrison's pouch, can be positive when you have a liver laceration and bleeding. It doesn't necessarily have to be, but a FAST exam can be really helpful. Again, if you're joining us sort of in the middle and haven't listened to all the episodes, we talk about the FAST exam in prior episodes, but the FAST exam, again, is going to be a view of the interface of liver and kidney, spleen and kidney, bladder, and looking up at the heart. Make sure you go back and listen to the other episodes if you want a little bit more detail. We can also do a CT scan, and the CT scan, like we talked about in the last episode, we're going to do a portal venous phase. Typically for trauma, you can time it for arterial and you can time it for venous. And this is something that I maybe didn't talk about in specific enough detail in the last episode, but when I talk about an arterial phase versus a venous phase versus a portal venous phase, this is all timing. So you're going to put the contrast in the body, and then once X number of seconds have passed, that's going to be venous timing. Venous timing versus arterial timing. Arterial timing is shorter because we're putting it in the vein, it's returning to the heart, and then it is pumping in the arteries. And then the venous is going to be later, and the portal venous is in the middle. And that's all just timing. It's not where you insert the contrast. I should have mentioned that last time. You also can do baseline laboratory testing if you know that somebody has a liver injury. Some centers will do like a hepatic function panel sort of early on so that they can compare later. This is not standard of care, but that's something to think about. And when we think about a hepatic function panel, typically people think about your AST or your ALT or your SGOT and your SGPT or something like that. I don't use that one. I use the AST and the ALT. But you truly want to think about your PTT, your PT and your INR. You want to think about your bile, so you're going to be your T-bili and your D-bili. You can think about your albumin. You can sort of think about the things that the liver is making as well. And something else that would clue you in, again, not a liver failure episode, but something that can clue you into liver failure or something going horribly wrong is like really low glucose, because the liver is playing a role in glycogen storage. And when you start to have low glucose, when you previously had an insulin requirement, if you're no longer having your insulin requirement and something changes really fast, or you're having really low glucoses, that can make you a little bit concerned that the liver is not doing what it's supposed to do. Also, you can look for things like jaundice, but again, not a liver failure episode. We talked about this last time, but the AAST, or the American Association for Surgical Trauma, has a grading scale for liver injuries as well. And they put the liver in pretty similar buckets. So if you listen to the spleen episode, we know that the size of the hematoma, the depth of the laceration, sort of how much of the spleen is involved, influences how the grade is made. And so what is important for knowing the grades for the liver is that one additional thing that you have with the liver is the segments. And so knowing the segments of the liver actually does become important when you are doing grading of liver injuries, because if it involves more than a couple of those segments, it sort of advances the grade, even if it fits criteria for another one. So we'll very quickly go through the grades. I know this part is not something that you necessarily need to memorize, but more so recognizing that, hey, as we advance in grade, these things are getting bigger, and from 1 to 5, 5 is worse, 1 is better, but sort of knowing like, okay, if it's actively extravasating, that means that it's going to be this grade, and I'm concerned. So one thing that's important to note about the anatomy is that you have Glisson's capsule. And so Glisson's capsule, or glissons, however you want to say it, is the capsule around the liver that when your liver swells and stretches, that's the part that hurts pretty bad. And so you have some pain from that, from Glisson's capsule. But the capsule is important because there is a difference between like subcapsular bleeding versus extracapsular bleeding. So for a grade 1, we have a subcapsular hematoma that's less than 10% of the surface area, or a parenchymal laceration less than 1 centimeter deep. That is pretty similar to splenic grades. And then moving on to grade 2, your subcapsular hematoma increases in size, so it can be anywhere from 10 to 50% of surface area, or the intraparenchymal hematoma can be less than 10 centimeters in diameter, or you can have a parenchymal laceration 1 to 3 centimeters deep, but less than 10 centimeters long. So there's lots of ways to slice it, but basically what this means is as you get bigger, like I mentioned, your hematomas or your lacerations are going to get larger. Once we get to a grade 3, this is where we have a ton of hematoma that's greater than 50% under the capsule, or you can start to have some vascular injury with active bleeding, but this active bleeding is contained to the capsule. So your hematoma, your non-active bleeding, can actually ruptured the capsule at this time, but as long as the bleed that has ruptured the capsule is no longer actively bleeding, it's a grade 3. If it is actively bleeding, that automatically makes it a grade 4. So vascular injuries in this setting, once it has exited the capsule, that's going to be a grade 4. Or if you start to have 1 to 3 of those segments involved, or 25 to 75% of a parenchymal laceration, that's going to be a grade 4. A grade 5 is going to be greater than 75% of a hepatic lobe disruption, or you can start to have venous injuries that are close to the liver, such as the retrohepatic vena cava or the major hepatic veins. And something that we talked about earlier was the Pringle maneuver, and we know that the Pringle maneuver is squeezing on the portal triad. And the portal triad, again, is your hepatic artery, your portal vein, and your bile duct. And what is not included in that is your IVC and your hepatic veins. So when you start to have bleeding from your hepatic veins, it is extremely difficult to get to those veins and you are in trouble. So hepatic venous bleeding is really scary. So a grade 5 liver is really, really scary. And you can lose a ton of blood from your liver. So then, just like we talked about with the spleen, there are different management choices and they fall into sort of the same buckets. So the first thing we can do is nothing. We can watch these patients and do our serial abdominal exams, noting and documenting the abdominal exam at a predefined interval, and then doing it with someone when we do handoff so that they feel what you feel and you guys are comparing notes. The next thing that you can think about is giving blood. You can give blood to correct a low hemoglobin or hematocrit if people are bleeding out and they need some volume. Another thing you can give blood for is to correct a coagulopathy. And so something to note is that cryoprecipitate, when we are giving cryo to patients to correct coagulopathies, cryo's INR is 1.7, and so typically around 1.7. And so if you are giving cryo to correct a coagulopathy, if that coagulopathy is greater than 1.7, if that your INR is greater than 1.7, awesome, you can give some cryo to help with that. If your INR is less than 1.7, giving cryo is not going to help. And cryo, for all of you who are listening, cryoprecipitate is going to be like a concentrated version of clotting factors that you can give to a patient. The next thing that you can do is embolization. Similar to splenic injuries, embolization is an option that our interventional radiology colleagues are super helpful with, and this is where they're going to enter through some vessel, usually the femoral vessel, and they are going to find their way up into some liver vessels. So they'll go in through the femoral artery and then intravascularly snake their way up to the liver and embolize what is bleeding. So there are some different ways that you can approach embolization. There's selective versus non-selective embolization, and it's just what it sounds like. So selective is going to be, okay, I know that you have bleeding from this subsegmental artery, and I know that I can get to it. And so I'm going to snake my way, and I'm going to find this branch, and then I'm going to find this branch, and then I'm going to embolize. And when you embolize, this is not an interventional radiology episode either, but when you embolize, you can either put a coil in or put a big blockage in that's going to sort of cut blood supply off to that whole area, or you can send in particles that are going to block off those tiny vessels distally but leave that area patent. You can do both of those things. So if you ever have the opportunity to rotate on interventional radiology or ask your interventional radiology friends questions, you will be working with them as a surgeon, and it is really interesting to know what they're up to. So selective is going to be, I'm finding the artery that's bleeding, or I'm finding the closest that I can get to it, and that's where I'm embolizing, versus non-selective is going to be embolizing a bigger vessel because you either can't get to it or the patient is too unstable. And so this is one of the wildest things that I have learned. Maybe that's an exaggeration, but you can actually embolize the hepatic artery. The whole hepatic artery can just be embolized, and the blood supply from the artery can be cut off to the liver. And the reason why is that you get most of your blood supply to your liver from your portal vein. So it's actually very possible to survive by embolizing the hepatic artery, the entire hepatic artery. It doesn't feel awesome. I don't think people really like it, and they get kind of sick and they don't like it, but they live. And so that is an option in a trauma situation. They often live. But you know what does get its supply from the hepatic artery? I say this like, okay, everything's going to be fine. The bile ducts get their blood supply from the hepatic artery. And so you are going to have ischemia of the bile ducts, and you can have biliary ductal abscesses. You can have multifocal abscesses in the liver after hepatic artery embolization. That is kind of like a high-level question that somebody may ask you, but it's important to know that if your patient needs a hepatic artery embolization, you should be looking out for infection. You should be looking out for infection anyway, but you especially should be looking out for infection because your patients are at risk for these abscesses, because now you have all of these bile ducts that have no blood supply. So that's important to recognize, keep an eye on. Also super cool that you can do that and be alive. The human body is amazing. So now that we've talked about embolization, you have some surgical options as well. So if a patient is too unstable to make it to interventional radiology, or they have a giant laceration that probably just needs to be surgically handled, you can go to the OR. And so when you go to the OR with a patient who is unstable, I didn't mention this in the last episode, but we can maybe talk about damage control surgeries. The liver is extremely bloody. And so when you have a liver laceration, especially a devastating one that requires you to go to the OR for the liver, it is likely that you are losing a lot of blood. And so the first thing that you're going to do for uncontrolled bleeding, usually at any trauma, is called packing. And so what you're going to do is you're going to use your laparotomy pads, you're going to roll them into packs, and you are going to push these into the abdomen to sort of push everything together and tampen on that bleeding, put some pressure in there, and sort of control what's going on. If things are totally uncontrolled and you cannot control the bleeding, you may put up, or you may have already put up in the bay, what's called a REBOA. And we've talked about REBOA before, but just a quick review. This is going to be a recessive endovascular balloon occlusion of the aorta, or REBOA. And this is a catheter that you put into the femoral artery. You snake up through the aorta, and if you're concerned for abdominal bleeding, you're going to place it in zone 1 of the aorta. So this is going to be above the celiac artery or the celiac trunk that's coming off of the aorta. So you're going to put your REBOA up above the celiac trunk, and then you're going to inflate a balloon, and that is going to either completely or partially occlude the aorta so that less blood is getting to the abdominal vessels, which is going to help control your bleeding. That means that you're going to have increased pressures up above. And so typically during this time, people will sort of come off of their pressures because they don't want to really give a ton of pressure to this patient who may have a TBI, who may have a lot of chest trauma. People are going to, anesthesia specifically is going to be really caring about the hemodynamics when the REBOA is up. But that is an option if you have a ton of bleeding. You're going to put your packs in, and then you can slowly take them out and sort of assess as you go. But something that you can do as a medical student is you can help make the packs if the scrub nurse is busy or if things are absolutely nuts in the OR, which sometimes they do get. You can say, may I have a bunch of lap pads? And you can help roll them up and get them ready, especially if a patient is totally crashing and you haven't opened yet. You can be like, do we have some laps ready? I can start making packs if you think that would be helpful. And sometimes it will be and sometimes it won't, but it's okay to ask and good to be prepared because when they need them quickly. So the whole idea when you get into the abdomen with a bleeding liver is to return the liver to its original configuration. So you can help control bleeding in this way, and you can literally stick your hands in the abdomen. You probably won't be as a med student, but you may watch somebody do this where they literally stick their hands into the body and push the shattered liver back into some semblance of the shape that it was in before. And this can help control bleeding while you figure out what the heck you're gonna do. And so that is one option. We talked about the Pringle maneuver one more time for the people in the back. The Pringle maneuver is squeezing the portal triad, and so you can either use your hands or you can throw a clamp on there. Especially if you're doing the Pringle maneuver for a long time, people will sort of dissect it out if they have time, and they'll throw a clamp across it so there isn't a hand in the way. But this is going to squeeze on the portal triad, which is the hepatic artery, the portal vein, and the bile duct. You may be asked this question. You should know the answer to this question if it is asked of you. Portal triad, Pringle maneuver. If this doesn't work and the liver is still bleeding, what is the issue? The issue is probably hepatic venous bleeding. And like I mentioned before, this is super duper duper hard to control. It is really hard to get to the specific vein that's bleeding because the veins are very intrahepatic and there's not really a good way to get to them without tearing through a ton of liver parenchyma. So that's something to note. Somebody may ask you that question as well. And then moving on, when we talk about surgical options for the liver, there are plenty of ways to surgerize the liver. One of them is a sectionectomy, so taking out a section of the liver, versus a lobectomy, so taking out either the left or the right lobe. You can do a total hepatectomy with emergent transplantation. And your options here are mostly what is available to me and how much of this liver can I salvage. So a healthy liver at baseline, you can take out a pretty large chunk of that liver and it will regenerate and you will maintain your liver function and you will be fine. If you have to do a total hepatectomy with transplantation, you better have a liver ready because you can't survive without it for very long. And the challenges with that, and we'll talk about transplant in a different episode, are resources. So having a liver available, being at a transplant center when this happens, the liver that you find is the correct type for you, the correct size for you, all these different things. It can be really challenging and probably very rare for a total hepatectomy with emergent transplantation to happen, although I'm sure because it is described that it has happened a couple times. So that you probably won't see. If you do, that's an incredible opportunity to see that, and I don't think it happens very often, and the stars have really aligned for that patient. However, some approaches for sectionectomy and lobectomy, oftentimes people will just throw some staple lines across it. It's not going to be a boutique surgery like you may see in a hepatobiliary service. Oftentimes they will throw a stapler across it. They will use what's called argon to sort of cauterize the liver, and that can help to control the bleeding and get things squared away. Another thing that you can consider that doesn't necessarily involve removing parts of the liver is called it's so hard for me to say this word, but I think it's hepatorrhaphy. I don't know how to say it, but it is basically throwing some stitches in the liver and pray that it works. And that is, again, just hoping to put the liver back into the configuration that you found it in. And so throwing some stitches in there and allowing it to approximate and close up that space that's just freely bleeding is the goal of that procedure. You can also use argon, like I mentioned before, and that can help to cauterize and help control bleeding. And then again, you can use packing. You can use packing with just normal laps. You can use packing with prothrombotic materials like Surgicel, like combat gauze. There's all sorts of ways to make prothrombotic materials and use them to your benefit. And so that can be done. And if you're doing a damage control surgery, like I guess you probably would be doing with a crazy bleeding liver, is you'll probably, if this patient is like unable to be totally fully controlled, they're cold, coagulopathic, and acidotic, they're entering that triad of death phase. If you're unable to control the bleeding or like totally finish the surgery, you're going to get that patient as stable as you can. You want your surgical field to be as dry as possible. So there's going to be as little blood as possible on your field, and you may leave the patient open or in discontinuation. And essentially what this means is there are specific materials that you can use that you can not close a patient's abdomen, put this device in, put it to suction, and it creates a fake abdominal wall for a day or two while you get that patient stable, and then you can take them back and formalize your surgery. So with damage control, which we can talk about in a separate episode, but this is a really good introduction to it, especially if you're with a patient who's crashing, you can't control their bleeding, there's all sorts of things going on. Leaving a patient open is an option. Leaving a patient packed and open is an option. Yeah. So if you're going to so hopefully we don't have to do damage control. Hopefully we can close the patient and everything goes peachy and everything is awesome. When you do a sectionectomy, lobectomy, total hepatectomy, all those sorts of things, you will probably leave a JP drain. And so the JP drain is there for monitoring. The JP drain that you leave is going to be there for monitoring. Like we mentioned in the last episode, JP drains are not usually left for draining blood, although if you were doing a transplant, you would have a JP there to sort of decompress the abdomen, especially if patients have ascites. But one JP drain there is going to be there for monitoring. And the monitoring in this case is going to be looking for a bile leak, because if you remember the anatomy, if you remember the pathology of the liver and sort of the microscopic view of the liver, you know that the bile ducts are sort of running amok throughout there. And so if you're cutting any one part of it off, it's really, really hard for you to adequately ligate all the bile ducts and stop bile from leaking. So you do your best and you use your argon and you use your combat gauze and you hope that all of that is sealed off in the way that it needs to be. But you're going to leave a JP drain and you're going to be monitoring for a bile leak. Bile can be really, really irritating to the peritoneum. And so patients cannot feel awesome. You can get a biloma, you can get an infected biloma. So you don't want a bile leak, so your JP drain is going to be monitoring for that. And you can check for a bile leak by looking at the JP drain and seeing if it looks bilious. But also, if you're getting a lot of other stuff out, what you can do is, if you know how to drink wine, which I don't know a whole lot about, but some reason I know about legs. So the legs of your wine, if I'm not mistaken, is when fancy people swirl their glass around to see the wine sort of like crawl up the sides. And then if you Google this and look it up, but the legs of the wine is like the stuff sticking up that like slowly works its way down. Those are the legs. And your JP fluid will have legs if it has bile in it. Okay, so the swirling of the JP drain, like a wine chalice, is going to be looking for the legs. And so if it's not clear that it's bilious, you can always give it a little swirl. Just make sure you're not pulling it out. And if anybody asks you, you can say, if there's bile in this JP drain, it will have legs like wine. And I know because I'm fancy. I literally could not explain to you what the legs are in any of those cases, but I know that that's the vocab word. Okay, so wrapping up, you can do repeat imaging a couple days after injury. My center likes to do that, but it's not necessarily required. But doing repeat imaging to see sort of how the bleed has progressed, if you do nothing about it, that's something that you can consider doing another CT scan. And then you can also check the serum bilirubin to make sure things are working fine after injury, making sure you don't have like scar tissue forming and you have like a bile duct obstruction. You can also check their liver function to make sure that you don't have any sort of like aberrancies, although I would guess that if you have a traumatic injury of your liver, you may have some transaminitis for a little bit because you have irritated and inflamed that liver. But not to worry, hopefully it will grow back in the way that it is supposed to. All right, friends, that has been the episode on traumatic liver injuries. In this episode, we talked about a ton of things, but some things I would recommend for you to do sort of in reviewing this episode would be reviewing the anatomy and the functions of the liver, making sure that you are sort of familiar with the grades, although I wouldn't recommend memorizing the numbers, just knowing that it gets worse as you go up. Knowing the broad classes of management, which include doing nothing but serial abdominal exams, giving blood, embolizing, and doing surgery. What sorts of things are you thinking about with an embolization and what can happen if you do a total hepatic artery embolization? And then what are you thinking about in surgery? What sorts of things can you do to control for massive bleeding when you open the abdomen? How can you as a med student prepare for that and help your team? What is the Pringle maneuver and what are you squeezing on? And then what are some surgical options? What is a sectionectomy versus a lobectomy? When would you do a total hepatectomy with transplantation? What is argon? All sorts of things for you to look up, but especially I hope that you look up what wine legs are so that you can wow your team when you shake that little JP drain and see that it's bilious. All right, friends, I hope that you enjoyed this episode. I am having a blast talking to you about solid organs. Next week, we're going to talk about kidney injuries, traumatic kidney injuries, and then we will move on to our next little series. So I hope you're having a good time. You can find us on Instagram. There's lots and lots of fun pictures and reels now reviewing some imaging. So if you want to see that, you check us out at Sterile Field Guide. Talk to you next time. Bye. That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.